This is a topic that I hear about all the time, but we really don't know which direction to turn in. So I'd like to thank everybody for joining us today. I greatly appreciate it. And even more, I can't thank Kim enough for stepping up and doing the program for us today. And I'm going to let Kim talk about herself a little bit because she's got a great background, and then she can get started.
Okay. Hi, everyone. My name is Kim Zerfas. I am a speech and language pathologist, and I work for UC Health Memorial Hospital. I work in our largest outpatient clinic, which is at the Printers Parkway Medical Plaza, right across the street from the Velodrome in Memorial Park. At our clinic, we offer physical therapy, occupational therapy, and speech pathology. We have 3 speech pathologists here at this clinic, 2 full-time and 1 part-time. And we all do all kinds of things. I've been a speech pathologist for about 35 years now. I work exclusively with adults. I see lots of MS patients. I see a variety of diagnoses: Parkinson's, brain tumors, strokes, traumatic brain injury, head and neck cancer patients. Swallowing is one of the things that a speech pathologist works on and focuses on. I grew up here in Southern Colorado. I am a Pueblo native, and I got my bachelor's and master's degree at University of Northern Colorado in Greeley. When I was first out of school, I worked at Barrows Neurological Institute at St. Joseph's Hospital in Phoenix, Arizona. And then after 5 years of that incredible heat, I couldn't stand it anymore and said I have to get back home to Colorado. So I've worked, and I've lived here in Colorado Springs ever since. I've worked in long-term care. I've worked in acute care in hospitals and worked in home care and outpatient. So I'm familiar with how things go for patients in all of those types of situations. I'm going to pull up my PowerPoint here. Swallowing issues in multiple sclerosis and how to manage them. So you guys will hear the term dysphagia frequently, and really all that means is difficulty swallowing. And it's basically like moving food or drink from the lips through the mouth, through the throat, and down the esophagus to the stomach. There are 3 phases of swallowing. The oral prep phase, you'll hear that referred to. That's how you get the food or liquid to your mouth and what you do with it, what you start to do with it in your mouth. Then we have the oral phase, which is how you manage or control the food or drink in your mouth, and that also includes chewing. And the tongue is very involved in that process. Then we have the 3rd phase, the pharyngeal phase, which basically pharyngeal is the back of your throat. That's the actual swallowing of the food or drink, directing it down the esophagus into your stomach. So the structures that play a part and a role in swallowing are your lips, your teeth, your tongue, your soft palate, the vallicula, which I'll explain here in just a minute, and the epiglottis. And I'll explain that in just a second. So we have a nice anatomical picture here. So this is what we all look like if we take a buzzsaw and kind of cut you down the middle, pull away half of your face and head, and look in at you from the side. So you can see the nose and nasal cavity. Then you've got this piece of white that you see, which your teeth are kind of attached to. That's your hard palate. You've got your lips and your bottom and top teeth. And then you can see this line that says tongue. And I know when you look at that picture, it looks very strange. And that is because when we see our tongue in the mirror, it doesn't seem to look like that. But this is actually the shape of our tongue. Then you see a line over to the right that says soft palate. That's like where the roof of your mouth starts to get nice and soft, and that is very movable. So when we swallow, the soft palate raises up and the back wall comes against it, and it keeps food and liquid from coming up and into our nose area and sinus area. So anytime you've been drinking something and someone has made you laugh really hard and it sprays out your nose, that's because your soft palate wasn't quite quick enough to catch it and keep it in your mouth. Then we have, you see a kind of dark heavy line that says the epiglottis. And this looks like it's white, but really it's covered with tissue. It's cartilage and it's covered with tissue. When we swallow, the epiglottis flips down and acts like an umbrella over our trachea, which is the tube that goes to our lungs, and helps to direct food and liquid down our esophagus, which is the tube that goes to our stomach. Then you see the line there that says vallicula. Right there where the epiglottis is and where the epiglottis kind of meets the tongue, there's a little space there, and that's the fancy word for it is the vallicula. If you've ever taken a pill or a medication and gotten it stuck there, that's where it's sitting, is in the vallicula, and you can taste it because the surface of your tongue goes clear back into that area. So you get that really icky taste from the pill. So that's basically the anatomy. So next slide, I'll be talking a little bit more about what each piece of the anatomy does. So our lips, they're responsible for keeping the food, liquid, and saliva in our mouth. In order for you to swallow, your lips must be closed. It literally is extremely difficult to swallow with your lips open. The lips need to come together and close to keep food and liquid in your mouth and saliva. Some people that have MS will tend to have problems with their lip strength, and they'll get some saliva or liquid when they're taking a drink leak out the front of their mouth. That's a common occurrence. Or they'll get changes in sensation where they don't feel their lips quite the way they used to, and so things can tend to kind of spill out. A big actor in our swallow is the tongue. It's responsible for moving food and liquid around in the mouth into between the teeth for the teeth to chew the food up, and from the mouth to the back of the throat for swallowing. The tongue also helps to form food that we've chewed up into what speech pathologists call a bolus, meaning it makes it into kind of a ball. It keeps it kind of all together so that we can swallow it in one swallow. Tongue base strength is extremely important in this. And one thing that happens with MS is weakness in the muscles, and that includes the muscles of the mouth and the tongue. The soft palate, like I've mentioned before, kind of rises up and it keeps food and liquid from going up into the nasal cavity. The vallicula, it's an area of space between the back of the tongue base and the attachment to the epiglottis. Usually this empties and clears out when the epiglottis slips down. For folks whose epiglottis doesn't want to work, and I just saw a lady about an hour ago for a video swallow who has MS and her epiglottis is not flipping down. So she gets a buildup of food and liquid in there that makes her cough. Epiglottis is made up of tissue and cartilage, and when swallowing, it flips down. We've said it acts like an umbrella over the tube to the lungs, the trachea, to protect the airway and to kind of direct food and liquid down the path that it's supposed to take towards the stomach. It also assists when we swallow, our voice box comes up and forward to be under that umbrella to protect us from food and liquid in the lungs. So if any one of these structures is impaired in any way, swallowing will be affected and your risk for developing aspiration or choking is increased. What aspiration is a fancy word for food and liquid getting into the lungs, and it generally will cause a pretty significant pneumonia. The teeth, the chewing pattern can be disrupted by multiple sclerosis. I see a fair number of patients with multiple sclerosis that tend to have what we call a munching chew pattern, where the jaws are just going up and down and they're not rotating. Most of us to chew our food use a rotary chew, where the bottom jaw kind of rotates to kind of grind that food up so that we can swallow it and digest it. Swallowing problems left untreated will lead to aspiration, causing pneumonia and likely hospitalization. Swallowing problems can also lead to malnutrition, particularly for some of our elderly folks who don't have MS, but even our elderly folks with MS, when they start to have swallowing problems, it becomes difficult for them to eat, and so they kind of solve that by eating a lot less or not eating at all. So some of the signs and symptoms of dysphagia, or again, our difficulty swallowing. frequent throat clearing during eating or drinking. If your voice sounds wet and gurgly after you have eaten or had something to drink. If you start to get a runny nose while you're eating or drinking things. Frequent coughing when eating and drinking. If it's somebody who's not able to communicate very well, if you have a loved one or family member with MS and they don't communicate well, if they start to refuse certain foods that they always used to eat before, that may mean they're having difficulty getting them chewed up and swallowed. If you are someone who is helping a person with MS and you're feeding them and you see that they've got leftover food on the tongue or under the tongue after swallowing, that's a sign that we are having difficulty swallowing. Pocketing of food, you'll hear that term, and that means a buildup of food in the cheek when eating. This happens to people who don't have MS after they've been to the dentist and it's all numb inside there, and so you don't feel the food when it starts to build up over there. Decreased intake of food, often with weight loss. That's a sign that somebody is having trouble chewing and swallowing. And if it seems to take a person a long time to get their food chewed up, particularly with MS, things tend to kind of work much more slowly. And so people that it used to take you, 30 minutes to eat a sandwich at lunch and it's now taking you an hour or more. That's a sign that, yeah, you've got some difficulty swallowing and chewing, and there's some things we can do to work on that. If you have 2 or more of these signs, you're at risk to aspirate. So you want to get with your physician and get a referral to a speech language pathologist for treatment. I told you we have a team of speech pathologists here at Printers Parkway. We also have a speech pathologist in our Powers clinic, which is kind of right behind the Lowe's. Penrose St. Francis also has outpatient speech pathology, and there are a couple of other speech pathology clinics around town. So you have lots of options for obtaining treatment if it's necessary. Impaired swallowing, also known as dysphagia, can be managed by speech and language treatment, and that may involve altering the diet textures that you're eating, training the use of compensatory strategies, use of vital stim, which this is something that I've been using. It's approved by the FDA for swallowing for speech use only. It uses electrodes that do some stimulation for the nerves and the muscles of the throat that can kind of tell those muscles, wake up, get busy, and start doing what you're supposed to do to swallow. We also train use of exercises for the tongue, lips, and throat. And we also do exercises for the voice box elevation to get it up and under that epiglottis as you swallow. Okay, so now our next little section here is going to be a couple of exercises that you guys can all do to try to maintain your swallowing function. So the first one, and my colleagues, the other speech pathologists here, and I refer to this as the peanut butter scrape. And this is an exercise that works on the tongue-based strength. In my estimation and in my career, I would say a good 80 to 85% of swallowing problems begin with weakness in the tongue base. If the tongue base is weak, you're going to have difficulty controlling the food in your mouth. You'll have difficulty getting it to the back of your mouth to swallow it. You'll have difficulty with retraction of the tongue base to create the kind of air pressure we need to push the food down through our pharynx and into our esophagus. And all you do with this is you put the tongue tip right behind your top front teeth, and then you just slide your tongue tip backwards along the roof of your mouth. I know that's kind of hard to see on the camera, but slide it backwards along the roof of your mouth like you have some peanut butter stuck up there and that you want to get it off. So almost like you're folding your tongue in half backwards. And here it says repeat 10 times and do 2 to 3 sessions per day. After about repeating that 5 times, you'll start to feel like a little bit of fatigue directly behind your cheek. And that is where your tongue base is. That's where your tongue attaches. And so working on that tongue base is the very beginning and management of all the swallowing difficulties. Our next exercise is for tongue tip coordination and tongue coordination. So what you're going to do with this, and this works on the base of the tongue as well. You put the tip of your tongue right in the middle of your top lip. And then what you do is you lick your lips in a circle and you do it slowly. Do it clockwise once and then go the opposite direction. Then you'll start to feel that right back behind your chin as well. Then we have, let's see, exercises for the epiglottis. So one of the best exercises for working the epiglottis is to gargle using small sips of water. One thing that's not on the slide, and as an aside, is there's a white paper out there that looked at what is an indicator for great risk of aspiration pneumonia. And the number one indicator is the amount of bacteria in your mouth. So take good care of your mouth. Brush your teeth frequently. It didn't matter really what diagnosis the person had, whether they had had a stroke or MS or Parkinson's, whatever. The amount of bacteria in the mouth was an indicator of whether they would develop aspiration pneumonia or not. Okay, questions. That was pretty quick and dirty for you guys. This is the number to contact the clinic if you have any questions for me after the fact. I'm going to open this up for questions now.
Is it good to drink with a straw?
Well, there's a lot of debate about that. For folks who can't hold the glass and get it to their mouth, that may be the only way that they can drink. The problem with drinking with a straw is you are sucking, which uses lungs to pull the fluid back. And sometimes you can pull it back and get it down into your lungs before your swallow can actually trigger. So a lot of times with folks that are having a bit of difficulty swallowing, as speech pathologists will say, don't use straws for a while. But it's very individual. Some people, that is the only way that they can drink.
When if I take a large drink of liquid, or if I do it while I'm talking to someone, or when I'm not concentrating, I end up choking on it.
Right.
Coughing it up.
Right. So sometimes for folks with MS, your swallow onset, they'll call it, or when the reflex to swallow is triggered, gets a bit delayed. So when you take a big drink of liquid, it can get to the back of your throat and start to go places it shouldn't before you can actually trigger that reflex to swallow it down to your stomach. And so that's probably what's going on with you. One thing you can do is just kind of try to really remind yourself to take smaller drinks. The other thing you could do, because your epiglottis, the timing with it may be off and you could get buildup in that little spot we talked about, the vallicula, is if you tuck your chin, get the drink in your mouth and tuck your chin just a little bit. You don't, just kind of like this. You don't have to put it down to your chest. Just bring it back towards your spine and swallow, and that might help a bit.
Thank you. I also have learned to take small bites of food.
Yes. And that also has to do sometimes with the tongue movement and controlling that bolus that we call it in your mouth. If the tongue is moving, if it's weak and it's moving a bit more slowly than it used to in the past, it's hard to control the food in your mouth, and you can feel like it gets to the back of your throat before you're ready to swallow, or you get it kind of down underneath your tongue or over to the sides. The tongue has the greatest role in the mouth of keeping the food moving to get chewed up, and to get it to the back of the throat in kind of one glob to swallow. And there's more exercises, and when we use the vital stim, that does help with the tongue movement as well.
And then I have one question that as I'm hearing you talk, I'm thinking, wait a second, it's become a kind of a joke with my family, because they always say, you're not a fish, you can't drink water, because I have a tendency of, I'll drink something, or my own spit sometimes will make me cough, and Mom, you're not a fish, you can't breathe water.
Right.
Is our family joke somehow attributed to what you're talking about?
Absolutely, because there's so many muscles. They're very small little intrinsic muscles that have to like do their thing with accurate timing all the way down that pathway, that if there's a little bit of mistiming that goes on, everyone's had the experience of taking a drink of something and just having it go down the wrong pipe, and we cough and sputter, and and even on our own saliva sometimes. You know, we can get a mistiming between when we breathe and when we swallow, particularly for folks that have what's called COPD. And there are quite a few MS folks out there that have that. That's chronic obstructive pulmonary disease, kind of also known as emphysema. They get reversed in how they breathe. Most of us, we're eating, we're chewing, we stop for a second, we breathe in, we breathe out, and then we swallow. And with folks, some folks that have MS, and then if you add the COPD or emphysema on top of that, that pattern gets reversed somehow. And so folks are breathing in as they're swallowing. And so when you do that, there's suction that's created, and it sucks food particles towards the lungs, which then causes more coughing and sputtering and choking as well.
Right. So I've had the issue where a little tiny piece of my food will escape and it'll go down my throat, and then I'll choke or cough, and my family like they get concerned because I'll turn purple because I'm barely getting air in.
Right.
You know, because the little piece of food has escaped before I'm ready for
swallow.
Or it misses the ball that you talked about. It misses that and it goes down.
Right. That's a common occurrence with foods that are particulate foods. And I will describe rice as one of those. Cornbread, no matter how moist you make it, is crumbly, and it likes to get everywhere in your mouth. So if your tongue is a bit weak and not good at controlling, and your sensation in your mouth isn't, 100%, those little tiny particulate things can kind of get everywhere. Tortilla chips, corn tortilla chips, same way. Those are hard to get chewed up and moist enough that they're in a ball that sticks together where they go down all at once. So one thing I suggest to my patients is add gravies and those kind of things. Add a little bit of jelly maybe too, if it's like a piece of toast, because that can be kind of crumbly. A lot of my patients have difficulty eating bread because the gluten in it tends to make bread, as you're chewing it, get kind of gluey and globby. And so some people do better if they toast their bread just a little bit. But to eat it dry, you really need to add some butter or jelly or something to the bread. Add just a little bit of moisture to those things that are really dry and crumbly, and that can help a bit.
Okay, thank you.
Sure.
I'm doing the Macmillan program while I'm in here. And I still, like today was my first intensive therapy with it. But I still had a piece of orange that went down that I still even feel like my food is still stuck, but it's stuck down here. But then I still feel like I have phlegm up in my throat.
Right. So the body's response to any kind of irritant or food or liquid being where it shouldn't is to produce phlegm. So anytime your throat, do you have reflux at all?
I used to. They're trying to get me in with gastro now.
Okay.
On my barium swallow, it did show that some stays left over in my throat.
Okay, so that's either in the vallicula or in what's called the piriform sinus, which I didn't put on the drawing because it's just a really hard spot to kind of see. So one thing you can do to keep food and liquid from building up in that vallicula, because some people, even though their epiglottis flips, the stuff just wants to sit in that vallicula, is again, just turn the chin back a little bit because it closes the vallicula off so something can't get stuck. So people that struggle with taking their pills, it sounds like the absolute opposite, and it's so counterintuitive to tuck your chin when you swallow, but it closes that vallicula off and keeps the pill or the food or liquid from getting stuck in there.
Yeah, because I can swallow 12 pills at once and have no problem, but I can't eat for nothing. And because I'm having problems swallowing, I'm not eating. So that's another reason why I'm here, because I'm 93 pounds and just losing weight.
Right.
So, but have you experienced good results with the Macmillan program? Have you?
I think you're thinking of McNeil. I am McNeil certified.
Sorry. McNeil, yeah.
No worries. And yes, you can get some really good results, because one of my I don't know, my thing that I say all the time to everyone is swallowing does not get better unless you swallow. And the McNeil program is kind of based around that. So people that, it's most common with strokes, that they can't swallow after a stroke and they end up with a tube feeding. If you don't start getting them swallowing something by mouth, it's going to be really hard to improve that swallow function. Part of my job is to try to get people eating and to assess the risk for the person and then try to manage it in the least risky way possible, try to minimize those risks. But it is still always a risk. But you know, if you're 95 and you weigh 50 pounds and you've got emphysema and you've had a stroke, then I'm going to be much more careful because you're at risk to just kind of die from this anyway. But someone who's young, like you, who has MS, I would try to figure out what kind of things you can eat safely, work on those and start bringing in the things that are more difficult, kind of a bite of those in between 2 bites of things that you do safely, and work. And the more you swallow, and I know with MS, your muscles kind of fatigue, but the more you swallow, the better that swallow gets. But it doesn't get better if you don't swallow. So doing the McNeil thing, I think, is a good plan because they're all about multiple repetitions and kind of mass practice as well. So they approach it from kind of the way exercise physiologists approach athletic endeavors of, okay, you want to do a better job of catching the football, we're going to have to do this about 100 times in a practice. They kind of use that exercise physiology approach to the swallow function.
Kim, I have a couple of questions too. One of them just came in. Somebody told me to ask about a nosy cup that'll help to keep the chin tucked while you're sipping.
It can. So a lot of people misunderstand and try to put their head way down, and then it's hard to tip a cup and drink. And it's probably hard to see what I'm doing, but my chin is way down towards my chest, and trying to tip a cup is a challenge. What you'd want to do is just pull the chin back a little bit, almost like you're going to sit up a little bit straighter. You know, back when you were in grade school, if your teacher came and tapped you on the shoulder, telling you to sit up straighter, you kind of brought your shoulders up and your chin back a little bit. That's what you want to do. Nosy cups are fine. And I'll be totally honest here, for folks that have extremely large noses, and they can't get the cup tipped enough because the rim of the cup hits the bridge of their nose. What you don't want is to tip your head way back and be drinking that way, because that opens the airway to more problems. So a nosy cup just has a cutout, and people get confused and try to drink from the cutout when it's actually you drink from the opposite side of the cutout, and it just creates a space for your nose so that you can tip the cup more easily without tipping your head. You can make a nosy cup out of a styrofoam cup or a paper cup by just cutting a U shape out of the edge of the cup there. And if that's something that works for you because you don't have much head mobility, you don't have, your arms and hands don't move very well to tip a cup because that takes some wrist rotation, a nosy cup
No. Get over there.
Yourself.
I have another question. It's been a few years and I cannot recall what the powder was called. There was a doctor in town that was having me buy, it's like a container at Walmart, and it'd be a large container of powder. And it was to help, they would mix it with water to help the swallowing. To make
so it might have been a thickener. Did it make the water a bit thicker?
Okay.
There's a bunch of different brands. There's Thicken Up, several. Some of them are cornstarch based, some of them are potato starch based. And then there are two brands. One of them is called Simply Thick, and I forget the name of the other one, that are gel. And those are based off of xanthan gum, which is a thickener that they put in things like Italian dressing and that kind of thing. The advantage of using the gel thickeners, even though they're a bit more expensive, is they stay the same thickness. They don't continue to thicken, which with the powder thickeners they can. The other thing is when you use the powder thickeners and you put them in things like water, the water tends to look cloudy, so it just doesn't look right. So if you have, if you're a caregiver for someone and they're a bit confused, they'll see that water and see that it's cloudy and not want to drink it because it just doesn't look right to them. So and it's also, they put them, Simply Thick is sold in packets that are like a ketchup packet you would get at a restaurant almost. So they're very portable. You can, throw some of those packets in your backpack or your purse or, a pouch on your walker or wheelchair and have those. So if you need to be on thickened liquids and you're at a restaurant, you have the ability to thicken that liquid easily. Some people need to be on thickened liquids because of swallowing difficulty, particularly with delayed swallow, and they could be what we call nectar thick, which is about like tomato juice, or it can be honey thick, which is more like if you think of pouring honey from a jar, that level of thickness.
Would we be helping somebody, or would it be a bigger problem if we had some of those small packets that we kept at our office for some of our clients?
Well, if they've been told that they need thickener, it would probably help to have some of those around, just, in a pinch if they're at your office and they don't have any thickener with them. Thin liquids are the things that are aspirated most frequently, particularly if someone has a delayed swallow reflex. And so frequently you see people on thickened liquids. My whole goal as a speech pathologist is if I can get a patient eating regular textures and off of thickened liquids, it's better. It's better for their quality of life overall. Okay. So, yes.
What's a first, other than me thinking I'm a fish, what are some of the first, I don't want to say warning signs, but first symptoms that might be easily ignored or construed as something else?
Well, kind of what you described, when things seem to go down the wrong pipe a bit more frequently. I mean, because we've all had that happen. We just get a mistiming and it happens. But if you start to have it happen, 2 or 3 times a week, hey, that's a sign something's not quite right. And sometimes it can just be as simple as the soft palate not working quite the way it should. And so you can't create the right, there's all kinds of aerodynamics and physics involved in it too that nobody wants to know about other than the physicists. But you have to create this pressure to push things down the right way. And then the sphincter at the bottom of your esophagus opens to let it into the stomach and pulls. So you create this aerodynamic push and pull. But if for people whose soft palate isn't working that well, or they have a real short soft palate that doesn't meet the back of their throat, it's hard for them to generate that pressure. And so things kind of slowly trickle through. You could be having some stuff that kind of stays on the base of your tongue towards the back that you don't see or feel, that then all of a sudden trickles down and heads down the wrong pipe. And what your body does is what it's supposed to, is cough and clear it out. That's the natural response to protect our airway. If you start feeling, if you start getting a runny nose while you're eating, even if you start needing to clear your throat more frequently when you're eating or drinking, those are some kind of early signs that there might be something going on with your swallowing.
Can these muscles right here, if they're super tight, can they play effect in swallowing? They
can. Yeah, you want to get those loosened up if you can. There's another exercise you can do, and even from a hospital bed you can do it. It's called a chin tuck against resistance. So it's best, although it doesn't work for most of our MS folks, to lay down flat on the floor and like you're going to do a sit-up, bring your chin to your chest and hold it up, and that strengthens all these throat muscles. For most MS folks, getting down on the floor is not a good plan, and getting up off of it takes a very long time and it's very difficult. So what I tell people to do is take a hand towel and roll it up like a jelly roll. So it's a roll about that big around. Put it under your chin and then just push your chin down into it and hold that for a count of 5 or 10. Then lift your chin up and then push your chin down into that again. That helps to strengthen all these throat muscles, because when you strengthen these outside ones a bit, it helps the ones inside as well.
Awesome. Okay, so chin.
Does that exercise help with the valleculi problem?
It can a bit, yes. Now, my patients that have had neck surgeries, sometimes that's very uncomfortable for them to do, and I say then don't do it. and don't do it to the point where it's painful.
Are there massage techniques? Like should I just sit here and just kind of rub it to see if that would help?
Rub it, loosen it up. Yes. And that also helps the voice too. You can kind of rub the voice box around a little bit gently. That also helps loosen up the voice.
So I totally went and got a towel. So
Hey, I have one too.
you said roll it. We're big on demonstrations.
There
So
you go. Good. And
Roll
I
it.
tell people don't use a bath towel because then it's going to roll up too big. Yeah. So just put
Okay.
that under your chin. Do it long ways. Now push down into it hard. And hold that for a count of 5 and then lift up.
oh yeah, right. You can feel it when it's okay.
Yeah.
So roll towel and then okay.
You might have to turn the towel a little bit as it gets kind of flattened out as you push in it. But yeah.
Every time you come up, rotate it.
Yeah.
couple
So some folks will find like a rubber ball and use that. I've just
Okay.
struggled to find a rubber ball the right size that isn't too soft. Like a Nerf ball is the perfect size, but it's so soft that
Okay.
pushing into it. So I've just like, you know what, let's try a towel and see. And that seems to work really well for most folks.
Okay.
When I was
the demo.
at rehab, a speech therapist had a ball that was barely compressible.
Right.
And she wanted to get me one, but wasn't able to do that before I checked out.
Right. Well, and one of those balls that you can barely compress really is creating a lot of resistance to push against. And you don't need a huge amount of resistance to strengthen those muscles. And a hand towel is something pretty much everyone has. Just roll it up and push your chin down into it. None of
Well,
these
I even
exercises-
noticed immediately you can
Yeah.
feel it.
None of these will cause harm to you. They will only help. And you could do them 100 times a day and it's not going to cause any harm.
Thank you.
The electrodes that you were talking about, or the
Yes.
neuro stimulation that you were talking about,
Yes.
how does that work?
So
Specific.
VitalStim is the main. There's another maker, but VitalStim is the first one that got the FDA approval. So that's our trade name for it. The electrodes are, about as big around, not quite as big around as a quarter. And there's going to be 4 of them that go on. And they're different than the electrodes that PTs and OTs use for electrical stimulation or TENS units,
Mhm.
because the filaments in these are in concentric circles. So they really drive the energy down towards the center of that and into the muscles here. They're much smaller than the electrodes that PT and OT use because we're dealing with a much smaller space and area. So what they do is send electricity and energy into the skin and into the nerves, because what we really want to access is the nerves to tell the muscles, hey, wake up and start doing the kind of movements that you're supposed to do. Because it's the nerves that control the muscles. The nerves tell the muscles what to do.
Okay. And you said it was called what again? Sorry.
VitalStim.
VitalStim?
Yeah.
Okay.
So that's the trade name for it. It's just neuroelectrical muscular stimulation. Most facilities do offer that. We offer that here at Printers Parkway and all of our clinics. There are still a few speech pathologists around in some of the home care agencies that don't provide it, but the majority of speech pathologists around do.
And it helps a lot with the
It
swallowing?
does. It does.
Because I wonder if that would benefit me more, also with the McNeil
Yeah.
McNeil
I
program.
would say I don't want to overstep whatever treatment plan that your speech pathologist is working with you on, but I would say I'm a person who I'm going to do whatever it takes to help my patients.
Mhm.
And so I'm going to leave no stone unturned. And so I would be using that as well.
Okay. That's something I can ask about.
Mm-hmm.
Thank you.
So when I was in rehab, I had a speech therapist who works with stem that attached above and below my lips.
Mm-hmm. So we use, with the electrical stimulation, with VitalStim in particular, we use different places depending on the muscles and the nerves that we want to impact. So some folks who are having trouble with their lips and their cheeks, we'll do placements up on the cheeks. And those are kind of nice placements. because the nerve that controls those muscles runs really close to the surface of the skin. And so it's really easy to access that nerve. So we don't have to use, we use milliamps. So we don't have to use a high milliamp to get what we want with those. And it starts helping. People will pucker up. When I had it on my face, like my face went kind of like this and my eye closed, and there was nothing I could do to stop that contraction. It was from the stimulation. And so it depends on the person's problem, the placement that we use for the electrodes.
Yeah, I thought that was pretty good. You used that on me. It was nothing scary.
That's
Yeah,
even
when you
better.
hear electrodes, you think, oh my gosh, she's going to shock me. And I will say it does feel a bit prickly here and there, but we get through that and get it to the point where the muscles want to make that contraction. And again, it does sound scary, but it's not that bad. Although I tease my patients because they'll tell me to turn it up. And I'm like, I really don't want your hair to stand on end. And I don't want you to like glow in the dark when you leave here. So
Sounds good.
especially my military patients, they're all about turn it up. I'm like, well, no, if it's not, it doesn't need to be up if it's at a point where we're getting that beginning contraction. So
Is that like a TENS unit?
it's somewhat similar. Yes, a TENS unit won't work for what we're doing because the electrodes are so different, and there's some things we have to be careful of, which is why we have to get certified to do it. We can't get it on the carotids and on the carotid sinus because we can cause a big drop in blood pressure that way.
I have a question. Will it affect your thyroid by any chance?
It should not. Really, the only contraindication to vital stim is if it's over a known cancer site. So if you've had a thyroid cancer within the last 5 years, we don't want to do vital stim on there. There is no data that says it causes a problem or causes cancer to grow more quickly, but there aren't a lot of people that want to volunteer for that study to say, hey, put this on me and see if it'll make my cancer grow faster. Not even broke, dumb college students will volunteer for that. They are doing studies with the kind of electrical stimulation that occupational and speech and PTs are using. And so far, what those studies are showing is that it doesn't seem to have an impact on the growth of the cancer or the spread of it in any way. But we would rather be safe than sorry for folks.
I don't want to be one of those test patients.
No, well, and if you've been cancer-free for 5 years and we know that you no longer have the cancer, then we just get permission from your oncologist and your doctors. I have to have an order from your doctors to put the electrodes on you anyway to say, hey, are you okay with us doing this? And then if the doctor says yes, then we go ahead.
Thank you.
I have a question.
Yes.
With swallowing problems, is it more beneficial to catch them earlier than later?
Yes.
Okay.
Absolutely, yes.
So when they're mild, it's a good time to start paying attention to them?
Yes. I would rather fix something on the front end than try to fix a bigger problem on the back end.
Okay.
And I tell this with my head and neck cancer patients that get radiation fibrosis that causes swallowing problems. Come in right away when you first start to have these problems before it gets severe, because that's harder to fix.
That's where I was asking, what are the first signs of it, so people can be a little more in tune. Well, especially with the nature of MS, so many of us, oh, it's this, it's that, you look the other way kind of thing. So that's why I want to be on alert for issues.
Right. Well, and some of the symptoms of, the difficulty breathing and running the fever and all of that, which are signs that you have an aspiration pneumonia, are similar to some of the COVID signs. So it's hard for the doctors to weed that out at this point. So yeah, it's, and yourself, if it hurts to take a deep breath, there's a good chance you're getting a pneumonia. Although you could test positive for COVID, but COVID turns into a lot of pneumonia as well. So
I was just thinking with the exercises that you just had on your little power thing and gave me the things, isn't that a thing to just sort of incorporate into the daily stretching and moving around stuff?
Yeah, absolutely. Into your kind of daily routine. If you're driving someplace, you can do some of these exercises. There's some that, have you sticking your tongue out, and I don't advise doing that in traffic because people think you're sticking your tongue out at them. However, you might get some strange looks, but who cares? If you're stuck at a stoplight, Or, you know, when the traffic backs up, as it tends to want to do here in Springs anymore, do some of the exercises. If you're just watching TV, do a few of the exercises as you watch TV.
Kim, can you tell us in the future, it'll be a while, but I know that you and I had talked about bringing up some other topics. What were you thinking of doing next?
When we had initially talked, there's lots of things that go with MS that the speech pathologist works with. Swallowing is one. Cognitive, your thinking and memory and word finding. That's one thing that goes with MS that speech pathologists
I'll
work
sign
on.
up.
I know, me too. Me too.
Your voice function is something that speech pathologists work on. MS voice is frequently affected by that. So those are at least 3 topics right off the top of my head that I think we could do. I had initially talked with Nikki about making this a monthly or every other month thing. I'm having a medical issue, so I will be off work for a couple of months. So once I'm back, I will get in touch with Nikki. I will be raring to go. I will talk with Nora. Also, she's one of my counterparts here at Printers Parkway. She's new with us. She's moved here from the Philly area, and she specializes in voice. She has been a professional singer, and she knows her stuff with voice. So I'd love if she and I together could kind of put something together for you guys as well.
Wonderful. Thank you. Thank you very, very much.
Because that's like, Kim, I noticed one thing with me, and I don't think I'm the only one. When I get tired or at the end of the day, I almost develop a lisp.
Absolutely.
Or a stutter almost. It's that the word that I knew in the morning that I was trying to say, I can't say by nighttime, or the lisp. That's what one of my kids pointed out the other day. Do you have a lisp? Only when I'm tired. So as human beings, it's just our nature. When we are fatigued, we don't function as well. If you've never had MS, but you have a bad night where you don't get much sleep, and you're up and trying to do your work the next day, and it's something very complicated, you may find yourself kind of doing the same thing, kind of over, did I just do this? Geez, this seems like it's taken me forever to get done. When we're fatigued, our brains just do not function on all cylinders. So folks that have MS, when you get fatigued, that's just expanded hugely for you guys. So it will affect your speech function. It will affect your swallow function, your ability to walk, your ability to word find, your voice, your cognitive function. You just get it at like triple the whammy that the rest of us in the human race get when we're tired. So that's why I think I'm a fish more at dinner.
Probably so. Yeah, absolutely.
Fatigue, okay.
Yeah.
And besides that, look at all the people that are defining you at the dinner table.
Right.
And you said you guys do cognition?
Yes, we do.
Because when I got admitted here, I had to do that whole cognition assessment.
Right.
And my neuropsych test came back with mild cognitive disorder. Yeah. But here, of course, I passed all the tests. So I feel like I'm going crazy.
Right. It depends on the tests that are given. There's one that they call a mini mental test that social workers in facilities are very fond of giving. And I kind of go round and round with those social workers because I feel like my dog could pass that test if he watched the news for an hour before they gave it. And so the social workers would be saying to me, well, this person could go home, they passed the mini mental. And my response is, yes, but they didn't pass the test that I was giving them. And this person could not problem solve this person. And it was a lady who had fallen and had a broken hip, and her daughter was leaving her home alone. And I said, my concern is if she goes home, she's not going to be following her precautions. She's going to dislocate her hip, or she's going to fall, and there's stairs in the house. And sure enough, they argued with me, sent her home, and she fell down the stairs and broke her arm. And then the talk was she was going to go home again, and the daughter was going to leave on a vacation right after this lady went home. And I said, you know what? I'm going to be crabby, you know what, about this time around. It is not safe for this lady to go home and be alone and be unsupervised. I don't care what your mini mental says.
And
yeah,
Michelle,
that mental test was easy.
Because they did the same thing to me when I was in rehab. But my doctor brought up, look at her stresses, her outside world stresses. When you're in the hospital and it's just you focusing on getting yourself better,
it's easier.
you don't have the kids, you don't have the spouse, you don't have
No
the
children.
household bills,
Mhm.
stimuli coming at you, which to me affects my speech and my cognition and things like that. If I have just a mom day, I'm a lot better the whole day versus
There you go.
when,
Versus life.
yeah.
Yeah.
So
Yeah.
keep that in mind too. It's,
Yeah, I have noticed that, like, since I've been here, it seems like I shouldn't be here because it seems like, you know, my cognition's good. You know, I can kind of walk a little bit better. You know, the swallowing's, well, not that great, but you know what I mean?
you can focus on you,
Yeah.
which, and so
And
you're
so-
not as drained.
Yeah.
So here's what I'll tell you guys about that. And maybe this is just a function of me as a person and as a speech pathologist, or the fact that I've done this forever and a day. My gut will tell me. I have patients that are testing out on everything I give them and testing out normal, but my gut's telling me there's something going on with their cognitive function. If that's the case, then I pull out a couple of other tests, subtests that will tease it out for me, and it will tell the tale. And I just step into, okay, higher level problem solving then. Like, how do you manage to get the dinner cooked and the phone's ringing and your child is asking you homework questions? That's a big cognitive load. So let's start adding, let's work on cognitive things, and let's start adding some distraction.
That's where failure happens.
Yeah.
Right. You know, so that your brain can start to get used to that. And let's figure out what strategies you need to put in place to try to manage that.
Kim, why don't we go ahead? I know your schedule's out for a few months, but if you want to look and see how things are, maybe the end of October, or I don't know when you're thinking, maybe the 1st of November.
Okay.
And let's see if we'll just plan and let the clients know that we'll be working on cognitive issues the next time.
Okay, if that's what you guys want for the next one. I wanted to start with the swallowing because that can land a person in the hospital with a pneumonia and potentially cause their death. And so I'm always about, let's fix the swallowing first and then work on the other stuff.
I love to catch it early so you can work on it when it's at a lower level.
Right.
So is that all right with everyone if we go into cognitive?
Yes. Yes.
Okay.
Fine.
Yeah.
Thank you.
Okay, everyone, I'm going to sign off. Thank you so much for your time
Thank you
today.
so much, Kim.
Thank
you.
you. Thank you so much.
It's very
Thank you.
interesting.
That's outstanding. Thank you.
Thank you.
Very, very
Bye-bye,
much.
guys.
Stuff, Kim. Thank you.
You're
Michelle.
welcome.